we've taken our regularly scheduled lung cancer living room that we normally do out on the West Coast in California on the road. And this is our first stop this year. So we were very, very happy to be here. Thank you all for coming. Those of you in the room and those of you who may be signing in online, we're very, very happy to have you. I should probably start by introducing myself. I am Danielle Hicks. I am the Associate Executive Director overseeing programs and services at the Bonnie J. Dario Lung Cancer Foundation. So my role there is to make sure everything that should be happening is happening when it comes to patient touch, patient services, patient support, and education. So with that, I'm going to make a quick introduction of Doctors Carbone and Doctors Presley, both from OSU, the James over here. We're so happy to have them here tonight. And I'm gonna let them do their own introductions because I can't do it quite as well as they can, especially without reading some big long bios, but it always means more, I think, when they tell it themselves and why lung cancer is important to you, why it became a chosen specialty, who you are and what you do. So Dr. Carbone, do you want to start?
That could take a while.
I know.
The why lung cancer. But so I'm the director of the Thoracic Oncology Center at the James and try to coordinate all of the lung cancer related services at that place, and as well as research at Ohio State for lung cancer. I've been involved with the Dario Foundation for many years, and I'm chair of the Science Advisory Board for the Dario Lung Cancer Medical Institute, and I find that the Dario programs are a fantastic resource for patients and caregivers. Why I came into lung cancer is kind of the short version of that is I love clinical medicine, and I had a PhD in genetics 25 or 30 years ago, and I was trying to decide, how I could combine those two fields. And I saw a lecture by a guy named John Minna, who was kind of the father of the field, and he really laid out what an awful disease with few options it was 25 years ago, and how they were finding specific genetic abnormalities in tumors, and I knew immediately that that's an important clinical problem, and I thought genetics could play a role in making it better, and it turned out I was right.
Great. Well, thanks so much for having me. I'm Carolyn Presley, and I'm a newer thoracic oncologist, and I'm also dual trained in geriatric oncology, so I really specialize in the care of older adults with lung cancer. But I'm really passionate about being a lung cancer physician because it's really a critical time in patients' lives where they have the opportunity now, they have a lot of treatment options, but it can also be a highly symptomatic disease and a very intense disease. And I'm really passionate about trying to help people live better with lung cancer as people are living longer, but we know that symptoms are a big part of the disease. And so really trying to figure out how do we optimally manage that and how do we maintain people's independence for as long as possible, and really support the family unit as well is really important to me. So, but I'm so happy to be here.
Thank you both so much. This is exactly why these two folks are sitting up here on the stage tonight, is their passions and where they come from the genetic and molecular standpoint, and the supportive and palliative care and symptom management from Dr. Presley's standpoint, because that is our topic tonight. We're going to be talking about advances in molecular testing, targeted therapies, immunotherapies, and then supportive care throughout, and what that kind of looks like. So with that, I'm going to jump in. I'm going to start with you, Dr. Carbone, and ask the question that is sort of the title of this meeting. What are some of the advances that have been made in the area of molecular testing? Actually, step back even for a second. What is molecular testing? And then let's jump into the advances.
So historically, we would be satisfied with a diagnosis of lung cancer, that you could look under the microscope, you'd see 3 cells under there that were clearly cancer, and you'd say it's lung cancer, and then in most cases you'd send that person to hospice because we didn't have options. But molecular testing really has transformed the management of the disease, and that means to characterize features of the cancer that help guide the treatments. And it's been discovered that certain specific features of cancers allow you to use what's called targeted therapies that specifically turn off the switch that those genetic changes turn on, and we see dramatic responses. But also molecular testing, I think, is increasingly going to apply to immune therapies as well, where we are desperately in need of figuring out what features of the tumor and the patient can help us pick the right immune therapy or combination of immune and chemo or immune and targeted therapies. So basically it means a more in-depth analysis of the tumor that it's important to stress needs to get done before you start any treatment. That too often I see patients who are panicked by their diagnosis, they get started on something, and then a month later their molecular testing comes back. And I think that's not acceptable because there are study after study that show starting with the right therapy first result in improved survival, decreased progression. And I think it's a message that really needs to get out, is that this molecular testing needs to be done from the start and before any therapy is chosen.
So when we're talking about that, you said the genetic changes to turn them to what turned it on, and how do you turn it off when you're talking about targeted therapies? And in and of itself, cancer is a genetic change, right? Can you talk a little bit about that?
Well, in simple terms, cancer results after there's an accumulation of damage to the DNA, and certain specific places are damaged that cause a cell to lose its normal regulation and become a cancer. Now, an average lung cancer will have hundreds of such damaged proteins, but some cancers have particular types of damage that are really what's called driver alterations, where that one alteration is the main thing driving that cancer. And now research and science has let us determine at least 6 or 8 of those different drivers, and pharmaceutical companies have developed drugs that specifically go in and don't just kill cells at random like old chemotherapies often did, but they go in and they specifically block that gene's protein that was turned on by the mutation. And so it's really true that we are making more rapid advances in lung cancer, specifically because our therapies are science designed, and research leads to that kind of progress.
And we're going to talk a little bit tonight about some of those known drivers, what's available, what's sort of coming down the pike in that. But as it relates to damage to DNA or changes in the cellular structure, this is also going to relate back to immunotherapies on some level, right? And why our bodies can recognize some mutations as being bad and get rid of them, and why they can't others, such as some of these more aggressive driver
Do you want me
type
to go
mutations.
into that a little bit?
Sure.
And chime in if you
layman
have
terms,
something
yeah.
to
Yes.
say. Well, your immune system has evolved to detect things that aren't supposed to be there, that aren't normal things. So if you get a virus, eventually your immune system will recognize that virus and it'll kill it. And the way it does that is not really important, but it's usually through detecting these virus proteins. And when I was saying that cancers have hundreds of gene abnormalities, it's not the genes that cause the problem, really. It's the proteins that are made from those genes. And it's a whole discussion to talk exactly what a protein is and what a gene is. But basically, these abnormal proteins are proteins that are not present in normal cells. And it's at least theoretically possible for the immune system to recognize a cell containing this abnormal protein as not supposed to be there and kill it. Not every abnormal protein is recognized by the immune system, but if you have more abnormal proteins, you're more likely to have a good immune response. And that's called something like, which you might hear in the clinic, tumor mutation burden. That's a parameter that's associated with the likelihood of benefit from immune therapy. And I didn't really say what immune therapy was, but basically some of the most successful recent advances have been in figuring out how to turn your immune system back on when to date it had failed to recognize the tumor. And that's because tumors have learned to produce proteins that shield themselves from the immune
Like
system.
the Harry Potter invisible cloak. That's sort
Or
of how I describe
I think of it as the Star Trek and force field. That just
Well,
means
and
that
you know-
we're different.
Yeah, and you know how I think of it
We're
like
different eras.
as a mother of 4, as
The
sort
shields are down, Scotty.
Yeah.
So then you pull off basically the immunotherapy pulls off the Harry Potter invisible cloak, and your immune system
Hey,
can see
there it is.
the
Right.
tumor cell and actually attack it and kill it.
Yeah. So let's go back a little bit before we dig too deep into the immunotherapies and talk about biopsies and molecular testing as a whole, because there are a couple of different opinions out there as to, although recently we just had some approvals in next generation sequencing, so that's really exciting. But what does a tissue biopsy look like? What type of testings are available for tissue biopsies, and what would you both recommend up front for diagnostic?
Well, it's really important that people who are involved in diagnosing lung cancer, if you have a suspected lung cancer, that the initial biopsy be of sufficient size to do molecular testing on. When I was in training 150 years ago, it was just enough to get a few cells and make a diagnosis. And so we actually became really proud about doing skinnier and skinnier needles and less invasive biopsies to make a diagnosis to send people to hospice. But the fact is now we need a reasonable sized biopsy to do this testing. And way too often, patients with suspected lung cancer get these tiny biopsies that are 20-year-old medicine, and then you have to biopsy them again to get a sufficient sample for testing.
What would be a reasonable size?
So in general, we try to get what's called a core needle biopsy, which is actually a piece of tissue, and not a typical biopsy is called a fine needle, was called a fine needle aspirate. And there you just stick a skinny needle in the tumor, you suck a little bit, and then you smear what you get on a slide, and literally you could get just handfuls of tumor cells there. Now they just use a slightly bigger needle, and actually women who've had breast biopsies know that they have a little machine that you can get a nice core biopsy, and they can get multiple biopsies with very little harm to the patient.
So with the molecular testing, what is it we're looking for? Because there's a difference between sort of just like a baseline lung panel, right, versus like what's a next generation sequencing? What are the differences of those two, and what do you recommend?
Well, you have a paper in next generation
Wow.
sequencing.
So, actually wanted to make one comment about the tissue biopsy. So right now, I think we are preferencing actually still getting tissue biopsies rather than just getting a blood sample biopsy. And
Yeah.
Talk
And
about
we'll
that
get
in a
to
bit.
oh,
yeah,
we're
yeah,
going to get to
yeah,
that. Okay, yeah.
Still, the
But,
gold standard is the tissue biopsy.
Right. I would say by and large, if someone's giving you the option in terms of shared decision making, definitely you want to. If it's safe to get a tissue biopsy, we absolutely would prefer that over just a blood-based test. So, but basically, this is probably one of the most exciting times in terms of genetics and lung cancer. And there are a lot of different tests that are coming out that are looking at a broad variety of the genetic makeup of the tumor. And there are different companies that are leading to different approvals of whether we're testing for 2 genes, if we're testing for 10 genes, or we're testing for over 300 genes. And so I think every institution and every community practice does it a little bit differently, but we recommend that patients get at least tested for about 6 to 8 core genes, that if you have that, we can absolutely give you a targeted treatment that would be, that's FDA approved, that's not going to be prohibitively hard to get because it's approved by insurance, what we call on-label, right, approval.
So these are all really, really exciting times. So let's move to some of these targets. What's happening insofar as drugs that will attack these driver mutations, where we've been, where we are, and sort of where we're going?
Well, it's really exciting what's happened with these targeted drugs. The initial targeted drugs for EGFR, for example, were not designed specifically to target the mutation. And they targeted normal EGFR, and they had a lot of side effects, and they didn't get into the brain very well. The drug that was first used for ALK fusions was not designed to target ALK at all. It was designed to target MET, and it just turned out it also did ALK. But as these targets became really clear that they were highly effective things to know and highly effective drugs, and just as an aside, the effectiveness of these drugs when used in a patient with these abnormalities is nothing short of transformational often. I've had people on ventilators within weeks of death go back to a normal quality of life, given the right drug for the right target. But what I started to say was that these drugs, over the last few years, companies have optimized them for better brain penetration, less toxicity, and the current generation of drugs have been shown to be superior to the first generations by far, with reduced incidence of brain metastases. The new generation of ALK inhibitor, for example, there's only about 9% of patients get brain metastases. With the first generation ALK inhibitor, it was about 50%. And brain metastases are a very morbid thing to get, and preventing the occurrence of brain metastases is extremely important. And in fact, many of those patients never need brain radiation. And since they're living now 3, 4, 5, 6 years on these drugs, they often live long enough to experience the toxicity of brain radiation.
So I have a question. As these next generation drugs come out, how is a physician, and you guys had the benefit of working in an academic setting, you can specialize in lung, I mean, it's what you do, you know these things as they happen, but for a private practice oncologist or someone in a more rural community setting, how do they keep up with this, and how do they know which, if there's 3 drugs, neither of them are a wrong answer, how do they know which ones
Some are more wrong than others.
Yeah.
Do you want to take that?
I mean, it's hard. It's hard.
Yeah.
And I think a lot of these drugs are actually really expensive for patients. So I do think we do spend a lot of time trying to get the right one covered. A lot of times I have seen patients will start something, waiting for that molecular testing to come back, and it turns out they actually have a different mutation, so they have to switch drugs. So that is something that I think hopefully with faster testing that won't actually happen, because that is something we do see in our patients that we don't recommend doing. But I think the toxicity profiles can be very different. And so that, I think, depending on the age of the patient, their kidney function, their liver function, that can help you choose one drug over another. But I also think signing up for like the FDA watches in terms of what's getting approved to try and really keep up with the FDA approvals that are coming out, that's the best way you're going to be able to get the drug covered for your patient too, to trying to keep up to date, is to really, you do have to keep up with the literature.
But the fact is, there's a lot of really good community oncologists out there.
Absolutely.
Yeah.
They're outstanding doctors, and I couldn't do what they did.
Yeah.
And many of them are in rural environments. They have to see leukemia, prostate cancer, breast cancer, colon cancer. We've had 8 or 9 new drugs approved in the last couple of years for lung cancer alone. It's completely impossible for them to keep up, though I'm really amazed some of them do. But what I tell patients is the best way to be confident that you're getting state-of-the-art molecular testing and state-of-the-art recommendations based on the last available data. you know, the FDA watch is fine, but, you know, I don't understand what they say in that half the time. I think
What do
the
you
best thing to
use?
do,
Yeah.
the best thing to do is to get a second opinion.
I want to say a huge, huge thank you to Dr. Presley and Dr. Carbone for coming out and talking with us tonight about this ever so important disease and how quickly it's changing and how, I hate to use exciting and lung cancer in the same space, but things are happening and they're happening fast and they're happening furiously, and
But
that's,
there's a lot of work that needs to be done
Yes.
still. I think we have to
Absolutely.
be very careful about saying it's exciting.
Exactly.
Because we're prolonging life dramatically, but we're often not curing people. And so there's a lot of work that needs to be done still.
Absolutely, absolutely. So a huge thank you to them for coming out and talking with us tonight.